Hi. Hi everyone. I'm Dr. Krishna Priya and I'm an orthodontist. I'm associated with SCO to help you with your preparation towards NEET MDS, especially in the orthodontic department. We've been discussing a lot of topics lately, such as habits and how to overcome them, and we've also discussed a lot about what are the basic study models and such. So today we are going to discuss about the retention and the how to overcome retention and relapse treatment, which is generally associated with any orthodontic treatment. So, if you have any queries today, kindly put up in the comment box so that they can address it after discussing the particular topic. Yes. So, with that, let's proceed to today's topic. I think everyone can see the screen. Okay. With that note, let's proceed to today's class. So the topic is retention and relapse. So before going in to address the MCQs and various concepts, first we need to understand what retention is. So Moyers has addressed retention as a terminology that the tooth which is optimal and stable in its new position. Okay? And relapse is the tendency of the tooth to move towards its old position after an orthodontic treatment. Basically, why is retention necessary is what we are going to see. So based on this retention topic, a lot of people have given a lot of inputs. So we have four different kinds of schools of retention that we follow, and each school has its own principles and ideologies. So firstly, we'll be talking about the occlusion school given by Norman Kingsley. So according to him, at the end of the orthodontic treatment, the occlusion plays a crucial role. Only when the occlusion is proper, then the retention will be stable. Then we've come to the apical base school, which is given by Longstrong. So according to him, the occlusion doesn't matter much, but what matters is the basal arch width. That is, yesterday we were discussing about Ashley House analysis, like how it takes into account the premolar basal arch width. That is the base of the mandible. So that is considered as the most important structure when we talk about retention. So coming to the third, the mandibular incisor school. So he plays a major role in this. He has given so many analysis on mandibular incisor. So according to this school, mandibular incisor school, it's all based on the lower incisor and it should be placed 90-degree or perpendicular to the mandibular plane. Or the lower incisor should particularly be placed perpendicular to the mandibular base. So that is what the mandibular incisor school is concerned about. And lastly, we've come to the muscular school. In muscular school, everything is left, but the ending occlusion and the buccinator or masseter muscle associated with that will be taken into consideration. So these are the four schools of retention. You should remember this because though the name is very familiar and it ideologically points towards the direction of the school it is about, but still you should know which school provides what. Occlusal school on occlusion, apical base school is on the apical base system. Mandibular incisor school is basically the position of lower incisor, and musculature school on the occlusal muscles involving in the occlusion. So I think I'm clear on the schools of retention. Okay. Then coming to the theorems of retention. So there are basically 10 theorems. Only based on this theorem, if you understood this theorem and the schools, then your retention and relapse topic is done. You should but understand the concept behind it, only when with which you can answer the MCQs. So the first theorem will be the tooth that has been moved tend to return to its former position. So whenever you do an orthodontic treatment, though you move to an optimal position of the tooth, but still the tooth has a tendency to come back to its original position. With this in mind, you have to plan the orthodontic treatment and give extra overcorrection or provide long-term retention as such. Should always have this in mind. This is the first retention theorem. The second one being elimination of the causes of malocclusion will prevent relapse. So basically, if you have a patient with tongue thrusting habit and you correct the malocclusion or open bite, but you fail to eliminate the habit, though you perform orthodontic treatment, this tongue thrusting habit will eventually bring about the open bite again. Okay, so the cause should be first eliminated before proceeding to the treatment. So the habit breaking should be done first. So that is the second theorem. The third theorem will be malocclusion should be overcorrected as a safety factor. Why? Because relapse is inevitable. Whatever you do, eventually the tooth will move back around 1 mm or 1.5 mm to its original position, original intended position. So overcorrection is indicated in certain cases, but it is not always indicated in all the cases. But overcorrection is a key. Proper occlusion is a potent factor in holding the teeth in their corrected position. For example, give it in a case of an cross bite or reverse bite. What will happen is that the lower incisor is beyond the upper incisor. So, in those cases, the correction of the occlusion, that is bringing the lower incisor behind the upper incisor, by itself is a corrected position. So, again, the lower incisor can't go forward because the upper incisor will hold it back. So once the occlusion is corrected, it will itself act as a retention so that the lower incisor it won't go back to its corrected position naturally. Okay, so this is one of the important points of the theorems of retention. Bone and adjacent tissues must be allowed to reorganize around the newly positioned teeth. So this is where the duration of the appliance comes into account. So however long we can make the patient wear the orthodontic treatment, but the retention part is very crucial. That is, they have to wear the retainers for a long period of time, that is more than 1 year. That is not to make the tooth accustomed to the new position. It is for the bone to grow. It is for the bone and PDL fibers to adapt to the new position so that the new position is accepted by the tooth and hence it will not move from that. So that is the main reason for the bone to grow and adapt to it. If the lower incisor are placed upright over the basal bone, they are more likely to remain in good alignment. So this covers the mandibular incisor spool principle. Lower incisor is of utmost importance because in lots of analysis you would always think about the lower incisor angulation. Correction carried out during periods of growth are less likely to relapse. So this is regarding the growth modulation. So when we address certain conditions like class 2 and class 3 during growth modification, then the corrections or relapse tendency will be poorer because we've used and manifested the growth and then we have done the orthodontic treatment. So in those scenarios, the relapse would be less. The farther the teeth has been moved, the less likelihood of the relapse. This case is like a canine, buccally impacted canine. So it has been moved really longer distance, right? So the tendency for the tooth to relapse will be less. Arch form, particularly in the mandibular arch, cannot be altered permanently by an appliance therapy. So the more we alter the mandibular arch form, the less is the tendency for it to be maintained in the same position because it has a high relapse rate. And the last theorem will be many treated malocclusion require permanent retaining devices. Mainly in cases of midline diastema, they require permanent retention because inevitably the incisors tend to move away from each other because of the labial frenum or because of muscle tendency, whatever it is. But still, some conditions require long-term retention. So I've just given the gist of what each theorem concept is like and what each theorem is important when it comes to retention or relapse. So, with all these schools of thought and basic theorems of retention in mind, we can now proceed to the MCQs. So, if you know all these things, then the MCQ is just a piece of cake. I'll be just dealing with certain retention scenarios we've seen here. So, basically, retention following the rotation correction, long-term retention is required. And for class 3 malocclusion correction, the functional appliance or positioners can be used as the retention appliance. And retention followed by the treatment of midline diastema, permanent retention is required. For deep bite, a bite plane is actually given for a longer period of time. In cleft palate, long-term retention is required. And also in multidisciplinary craniofacial associated conditions, we've always given acrylic-based plate for the long-term retention. So these are some of the common questions like what kind of retention is used for what kind of malocclusion. So you can just take a note of it. And now with all these knowledge about retention and relapse, we'll go on to the MCQs. The purpose of the post-treatment retention of an orthodontic case is bony changes. Tongue thrusting, encourage space closure, let the patient get used to the new functional position of the teeth. I understand everyone would be looking forward to the fourth option, but the answer is first option because most inevitably what we need is the bony changes or bony remodeling so that the tooth remains in that position more rather than to let the patient get used to the new functional position because the patient getting used will not make any change but the bone forming there will not allow the tooth to move past it, so that is more important. Yes. So during ortho treatment, the teeth are moved by applying the forces with them, which causes the bone surrounding the teeth to get remodeled. So here you can use a lot of terms like osteoclast and osteoblast. So osteoclasts are the tooth or inflammatory mediators which resorb the bone, whereas osteoblast is a cell which will help in the formation of bone. So osteoclast will be moving the bone away from the original position so that the tooth is being moved. Okay, and the osteoblast will be in the place where we intend the tooth to be. So it will just form the bone there, and which will intent prevent the movement of the tooth. So bone formation is very essential when it comes to the retention and relapse. Retention can also help prevent tongue thrusting. Retention can help and prevent them, but if you do not remove the cause, then even though if you give the retention thing, the cause will in turn bring the malocclusion back. So the cause should be eliminated first, followed by orthodontic treatment, followed by retention, which keeps the habit at bay. Yes. So relapse after orthodontic treatment can be totally prevented by inactive fixed implants, Holly's retainer for 1 year, wearing an activator for 3 months. None of the above, some degree of relapse is normal. So as I already mentioned, relapse is one thing that you can totally, it cannot be prevented. So the keyword here in the question is totally prevented by. It is inevitable. It is obviously present the relapse, but it can be minimized by wearing the retainers properly. So since the question here is totally prevented by, the answer would be D. Some amount of relapse is normal. So factors such as age, growth, and natural changes in the teeth and surrounding tissues can contribute to relapse even with proper retention. So relapse after an orthodontic tooth movement is due to what are all the different conditions wherein relapse occurs. So supracrystal gingival fibers, abnormal pressure habits, improper angulation of the teeth, and all of the above. So basically, relapse is something that happens after the completion of an orthodontic treatment. No orthodontic treatment completes with an inappropriate bite, nor without correcting any habits, and nor improper angulation of the teeth. Only when the proper occlusion needs are met, and only when all the tooth are in their optimal position, then orthodontic treatment ends and the retainer is given. So, beyond which, when a relapse occurs, it may be because of the supracrystal gingival fibers, because that is the main issue. In this picture, if you can see, the supracrystal fibers are in this area, especially in conditions with the rotations, right? So, when the supracrystal fibers fibrotomy is not done, then the rotation relapse has a more likely chance of happening. So, when it comes to relapse, the most important thing is supracrystal fibers because in rotation correction they play a major role. Abnormal pressure habits and improper angulation of the teeth, though at the end of orthodontic treatment, they are not finished the same, but still they may contribute. So, since the question is relapse after orthodontic tooth movement is due to, it may be mainly because of supracrystal gingival fibers, but both the pressure habits and improper angulation of the teeth can also be one of the features for it. So, the answer is so. With that in mind, we have to move to the next question. See, imagine supracrystal gingival fibers is present on the horizontal surface, so it is mostly associated with rotation correction. If you want a tooth to be rotation correction to be done, then you do a procedure wherein you cut these fibers and you'll enable the PDL fibers to form in the new position where the rotation correction has been completed. So take that into account. So moving to the next question, main cause of relapse after orthodontic treatment is what? So what is the reason the relapse is happening? Density of cortical bone, persistence of tongue and finger habits, persistence of oblique fibers, persistence of free gingiva and transseptal fibers. So basically, you should understand that where the transseptal fibers are. They are some of the supracrustal fibers. So these transseptal fibers are horizontal connection between adjacent tooth, and they run along the entire arch form. So this gingiva and the pedal fibers play a very important role in keeping the tooth in its original position and maintaining a memory of it. So the main cause of the relapse may be because of the persistence of free gingiva and the transseptal fibers. So in the previous question, okay, so this question and the previous question is mostly frameworked in a similar manner, but the previous question was relapse was due to, it may be due to a lot of conditions, but mostly the primary cause will be gingival fibers, and other causes like habit and improper angulation, they may also be one of the factors. So if you have the options like all of the above, go for it, or else if they've not given the all of the above option, but the gingiva and transeptal fiber are one of the option, kindly go for it, because it marks the most important aspect of relapse condition. Yes. Retention in orthodontic treatment means holding skeletal growth till puberty, retaining the pre-treatment smile line, retaining profile, maintaining the newly moved teeth in a new position till it stabilizes. So basically, it is the last option. Retention and relapse are two different things, but they are closely associated with each other. In retention, we wanted the tooth to remain in its newly formed position. So we give some time for the bone to form there and adapt there so that it won't move to its original position. Relapse is a naturally occurring thing wherein the tooth inevitably it moves to a certain extent to its original position. That is relapse and this is retention. We should understand the difference between the two to proceed with a lot of MCQs. And this retention can be achieved through a lot of appliances, because we have different concerns when it comes to different appliances. So basically, if the patient still has tongue thrusting habit, then in the retention appliance we can give some cribs and train the tongue in such a way that the habit is minimized. And sometimes this retention we also use a Hawley's appliance like a bow in the front to limit the amount of proclination the patient has. And sometimes we give S6 retainers. They are basically like invisible retainers. They are like a tray which the patient can wear without anyone else knowing about it. So there are different kinds of retainers given for specific conditions. And there are also retainers which is called as lingual bonded retainers. Those are fixed retainers which is attached to the tooth in the lingual side, especially in the lower region. So the next question. Riedel's theory of retention advocates that. So, what is Riedel's theory? So, before going into that, let's address the MCQ answers given here. Change in the mandibular dentition is a must for retention. No change is required in the mandibular dentition for retention. Change in mandibular retention in pre-adolescence or change in the traumatic teeth bite. So, Riedel's theory is usually concerned with the lower incisor or the mandible. So, the change in the mandibular dentition is a must for retention. What he means to say is that whenever there is a change in the arch form or the lower incisor position of the mandibular dentition, retention is must, or else the relapse tendency will be high. It is proposed by Rolf Riedel. He suggested that the mandibular dentition is necessary to achieve a stable long-term retention of the maxillary teeth after the orthodontic treatment, because the mandibular base consists of an apical base which is of core importance in the retention. So only when the mandibular arch form is stable, it will provide suitable occlusal forces for the maxilla to be stable. And thereby, Riedel suggested that the mandibular dentition should be of given utmost importance when it comes to retention, so as to have a long-term stability for any orthodontic treatment. So, a change in the dentition is necessary to achieve the stable long-term retention of the maxillary teeth after an orthodontic treatment. Thereby, the position of mandibular incisors play a very crucial role in determining the stability of the maxillary incisors. What he means is that the mandible forms the base mark upon which the maxilla also comes in, occludes in a certain level to have a stable relationship. So, correcting the mandibular dentition during orthodontic treatment can help in minimizing the risk of relapse and achieve stable long-term relationship and also the retention with the maxillary tooth. So, appliances like twin block or herbs appliance can correct the mandibular dentition. So, he means to say the mandibular dentition correction during the growth spurt or pre-adolescent stage, because by correcting it we can achieve a stable relationship between the maxilla and the mandible. So this is Riedel's theory. So imagine Riedel's theory is mostly associated with the mandibular dentition and also the mandibular incisors and its impact on the maxillary tooth. So coming to the next question, which of the following surgical procedure aid in the prevention of relapse? So in usually retention and relapse, a surgical intervention is very minimal. So as I mentioned earlier, correction of the transeptal fibers or fibrotomy, especially in rotation scenarios, right? So that is a surgical involvement that is usually taking place when it comes to retention or relapse. Sagittal split technique, alveoloplasty, segmental osteotomy, circumferential supracrestal fibrotomy. So the last option would be there to correct the rotation. So since okay, imagine that I'm having a tooth here and my fibers are overlapped like this from both sides. So I've tried to rotate my tooth to a correct position, but my fibers are attached to the tooth in its initial position like this. So whenever I'm removing a force, it will tend to rotate my tooth to its original position as well. So in order not to happen like that, I should seize my fibers away from my tooth in such a way that they'll bond to the corrected position of the tooth and maintain that position of the tooth for a really long period of time. So this rotation correction alone involves surgical intervention, other than which surgical intervention is not necessarily associated with retention. So the answer would be D here. So the remaining surgical intervention is associated with general orthodontic treatment. So see, as I've mentioned, right, the circumferential supracrystal fibrotomy is a surgical procedure. It cuts the gingival fibers along the teeth. But cutting them means not like removing them entirely. We are just cutting its contact with the tooth. It will again form contact with the corrected position. According to Tweed's philosophy, the correct placement of which teeth is necessary to minimize the relapse. So Tweed, so we are talking about lower dentition and lower incisors. So the answer would be lower incisors. So generally, we have so many analysis in cephalometry in order to identify what parameters the patient is coming in, whether they have a prognathic maxilla or orthognathic maxilla and such conditions. So generally, cephalometric analysis are being done, out of which Tweed's analysis is of utmost importance because it will give us the position of the lower mandibular incisors, based on which a lot of treatment planning is executed. So whenever it comes to Tweed or even Radel, the lower incisors and the lower dentition plays a major role. So don't forget that. So the answer here is lower incisor. I've given a diagram of it. So in Tweed's philosophy, he also marks an angle called IMPA. That is the angulation between the incisors long axis to the mandibular plane angle. So if it is more than 90, 95, then the stability of the treatment is poor. So it has to be 90 to have a proper stability. That is his concept of ideal occlusion. Done. So the next question is, lower incisor school of thought for retention by Tweed suggests that from. So as we thought, right, four schools of thought are there, and upon which the lower incisor school of thought was lower incisor position should not be changed, crowding of lower incisor should be corrected, normal ovigit and ovibite should be corrected, lower incisor should be upright over the basal bone. So it is only the upright over the basal bone will be the right answer, because the position of lower incisor determines the stability of the entire treatment. So don't take the first option which says should not be changed. No, we have to change it in such a way that it is upright on the basal bone. That is the school of thought. So some other factors can also contribute to relapse, which includes improper alignment of the tooth or improper angulation, improper occlusion, and over interdigitation. So these are the other factors. So the orthodontic treatment should be finished in such a way that the occlusion is perfect and everything falls into place, and the stability between the apical base and the maxilla is also proper. So these are the other factors, but main factor is that lower incisor should always be perpendicularly placed over the basal bone. Orthodontic correction of which of the following is most easily retained? So the question is, which is easily retained? That is, which doesn't require an intervention for the tooth to be in its corrected position. So we were discussing this earlier, right? So whenever we have a cross bite, okay, the one tooth is above the other. For example, this is an anterior crossbite. The upper tooth should always be before the lower tooth. In crossbite, what happens is that the lower tooth is beyond the upper tooth. This is a poor bite. So in the anterior crossbite correction, what we generally do, we jump the bite, okay, and then we make sure the lower incisor goes behind the upper incisor. In such a way, even if the tooth tries to go to its initial position, it can't jump the bite again. So this by itself acts as retention. So it is very easy for maintaining. But in situations like crowding, okay, even though when we correct it to it, it can easily go and migrate to its old position or diastema. We are just pulling and pulling the tooth together in order to correct the diastema. But it's very, very easy for them to move back. So severe amount of retention and permanent retention is required to bring them together. And also spacing, it's very much easier for the tooth to drift away from each other when they have a space. So the easiest method of maintaining a retention is anterior crossbite, but the most difficult ones are midline diastema. Spacing is very difficult to maintain. That's why in spacing conditions they generally go for the permanent retainer. That is called incisal guidance, what I was explaining about this. So all of the following do not require definite retention. That okay, this is exactly the question I was discussing earlier. So not everything requires a definite retention. So anterior cross bites, they do not require definite retention because their position act in such a way that they provide retention. But cases by serial extraction or posterior cross bites or rotation of the teeth, sometimes they do require a kind of retention to them. So the question is, all of the following do not require definite retention. For example, diastema. So all of the following do not require definite retention, but still the rotation of the teeth, they do require the definite intervention. So as I already said earlier, the rotation correction is very difficult because we need to cut the supracrestal fibrotomy in order to bring it back to its original position. And also regarding spacing, it's difficult to be kept in that same direction. It has to be brought together by retention. So yeah, they require definite retention as they involve changes in the tooth position and the associated relationship. A corrected anterior crossbite is retained by overcorrection, normal incisive correction, Hawley's retentive appliance, or palatal acrylic appliance with no labial arch wire. So we just now saw that, right? Crossbite, it is retained by the normal incisive correction. We generally don't do overcorrection, or we generally don't employ any retention appliance just for the sake of maintaining it. The normal incisive correction by itself is eventually okay in maintaining the retention of the particular scenario. Permanent retainer is sometimes needed in case of. So, as I was discussing, different kinds of retention appliances. That one such kind is permanent retainer, which is not removable by the patient. So these are the permanent retainer. So they are called as fixed retainer, which is stuck to the lingual surface of the tooth. I'll be having a picture later, so you can appreciate it. It's mainly given in case of severe rotation. In associated along with the perisession, that is circumferential fibrotomy, along with that, we also give permanent retainers so that the tooth will not derotate again. So rotations usually comes under the scenario wherein they'll need definite retention systems. Prolonged retention is usually needed in Testema, yes. So definite retention and prolonged retention are something which is quite different. So definite retention is that the retention is a must. So it will come under rotation and such corrections. But prolonged means when though definite retention is there, but still they have to be wearing it for a really long period of time. Because whenever we remove the retainer, again the tooth has a tendency to drift apart from each other. So midline diastema is very, very difficult in maintaining it without a retention appliances. So permanent prolonged retention is required for midline diastema. Purpose of the post-treatment retention of an orthodontic case is what? We've discussed this question earlier, though the question is coming again in a different form. Bony change to prevent tongue thrusting, to encourage the space closure, or to let the patient get used to the new functional appliance. It is the option. Okay, the option there was to allow the bony changes, But here they've given us to let the patients get used to the new functional position of the teeth. Because if the teeth is not retained to their original position, they are likely to relapse towards their new position. And additionally, the retention also helps to prevent the functional relapse due to the habits like tongue twisting. So, coming to the next question, relapse after orthodontic treatment can be totally prevented by, what will be the answer? Some degree of relapse is quite normal. I think we've discussed this question too. 1 minute. Yes. Some amount of degree of relapse is quite normal. Yes. The most common type of removable retainer is. So the most common type is obviously Holly's retainer, which we generally give to the patient. It is a removable appliance which is made up of acrylic in the center with a labial bow which corrects the proclination of the tooth. And also for the retention purpose, we've given uh, clasp associated with the molar region. So it fits around the teeth and thereby it holds the teeth in its original position and also preventing further proclination. They are very popular because they are durable, they are easy to wear, they are adjustable, and also they are very easy to clean. They also may help in maintaining the oral hygiene of the patient. So the other type of retainers include Schwartz retainers. They are very much similar to the Holly's retainers, but they are more streamlined design and they do not cover the palate. Like Holly's appliance without coverage on the palate will be the Schwartz retainers. And something called as plastic positioners can also be used at the end of the treatment. They are custom made for a particular patient by taking the impressions and they are 3D imaging technology. Crozet appliance are also removable kind of orthodontic appliance. It use very much complicated wiring system to guide the tooth movement to its original position. So the choice of retainer depends on the patient as well as the dentist, depending upon the needs of the individual tooth or the maloclusion. So the best retainer advised after the closure of midline diastema is bonded retainer. So we've discussed that midline diastema is a very difficult condition because it needs the prolonged retention. So the prolonged retention means long-term wear, which comes to the point that we are giving bonded retainer in the lingual side, so that the retention plan will also be prolonged and it won't be any difficulty for the patient because the patient will not forget to wear it. It will be long standing and it will also be a permanent one. Bonded retainer. So they have several advantages over other types of retainer. They are permanent because the patient do not continuously take it away or wear it again and again. They also provide continuous gentle pressure to keep the teeth in its desired position, thereby avoiding the relapse. So they are difficult to clean, but it's very easy to maintain them. In case of orthodontically treated midline diastema, which retainer should be used? So just now we decided it's lingual bonded retainer. Because Holly's retainer can be given to the patient, but prolonged usage is necessary, and sometimes if the patient forgets to wear it, then again the relapse is inevitable. So when it comes to spacing or midline diastema, always lingual bonded retainer for prolonged retention or permanent retention is indicated. An orthodontic positioner is worn to separate the teeth before banding after the removal of fixed appliances for retention in the place of fixed appliance to move the teeth. None of the above. The answer would be after the removal. Basically, a positioner is worn after the orthodontic treatment is complete and it is used as one of the retention appliances. So, this is a picture of a tooth positioner. Its primary purpose is to fine tune the position alignment of the teeth and also helps to maintain the early stages of the treatment results. They're made up of soft material that fits over the teeth and gums. It's very comfortable for the patient, and they can also help in correcting minor corrections like minor relapse areas, which that may have occurred after the braces have been removed. But positioners may be an effective tool for achieving optimal tooth alignment and maintaining the results of an orthodontic treatment. So they're generally worn for a period of several months, and after which they can be replaced by other kinds of retainers to target the specific needs. So coming to the next question, best retainer advised after the closure of midline diastema is. So this question is repeated in almost all the exams and syllabuses. So you should have a complete and clear picture of differentiating different moleculations with different retention plans. So Rotation is supracrystal fibrotomy along with prolonged retention. For spacing and midline diastema, it is prolonged retention along with bonded retainers, that is permanent retainers. And for anterior crossbite, retention is not actually needed because the incisor position or guidance itself serves as an retention. So this is the gist of what we've been revising till now. And about tooth positioners that we discussed right now. Brandons per retainer is given in the cases of what? Midline correction and retention, retention for correction of labiolingual correction, or in case of deep bite, or in case of breaking habits. So mainly it is band and spur. As you've seen the picture, it is used mainly for the labiolingual correction, that is forward and backward correction. So this kind, they are associated with the they are made in such a way that the labiolingual correction is maintained, and they also have provide for the retention for them. The retainer consists of a metal band which encircles one or more teeth, and it applies to a plastic spur which is associated with the adjacent teeth, so that they tend to apply pressure on only certain direction, and thereby the labiolingual correction is achieved while the patient is on retention. So it is a custom made one to fit each tooth, and it's typically worn full time for several months following an orthodontic treatment. So this is a new kind of brand and spur kind of retainer. Bonded retainers are popular in which areas of dentition? Usually, bonded retainers are given in lower anteriors, because even though we give in upper anteriors also, but lower anterior bonded retainers is very important. They're made up of a thin, flexible wire that I have showed the picture earlier, right? So they're covering from canine to canine. They are very popular in the lower region where the teeth are more prone to shifting forward. As I've already mentioned, the lower incisor position is very important according to the Riedel school of thought and also according to Tweed school of thought. So that position is essential in establishing the stability of the treatment, also in correcting the maxillary positions. The choice of retention for lower incisor following orthodontic correction is. So, what is the choice of retention? As we've already discussed, it is bonded canine to canine retainer. It is the best choice of retention, permanent retention or bonded retainer. It's best suited for a particular patient depending on several factors like location and extent of the orthodontic correction, and also the patient's preference to their particular lifestyle. Tooth positioner is used as a retainer in the posterior teeth. Most beneficial effect is, we've seen a image of tooth positioner. So aesthetic due to its clearness, gingival massage inflamed during orthodontic treatment, final setting of occlusion used in uncooperative patient. So basically, tooth positioner doesn't provide any pain to the patient on wearing. It is made up of a very flexible material with which it will provide minor corrections or minor movements in the final position of the tooth after an orthodontic treatment. So the answer would be a gingival massage. It will extend till the gingiva. Generally, at the end of an orthodontic treatment, since we provide constant force, in gingiva will be sometimes inflamed. So using a positioners, it will sometimes be useful for the gingival massages to bring it down from its inflamed state. So tooth positioners, one of the important effect is like reducing the inflammation of the gingiva. Retainer bow is labial bow from. So as we discussed about Hawley's retainer, whose the labial bow was given to prevent the proclination, right? It is extended from only canine to canine. But Beck's retainer bow, it is extended beyond that, from molar to molar. So you have to find the difference between Hawley's and then Beck's. So Beck's retainer bow is from molar to molar. It's used in combination with other type of retainers or appliances to provide a comprehensive post-treatment effect. That is, whenever you don't only need the upper anterior proclination to get resolved, but you also need the molar correction or premolar to be in that particular spot. Then you go for Beck's retainer bow. Okay. So with that, we come to the end of today's session. So anyone having any doubts regarding it? So I'll just sum up what we've discussed today. We've discussed about 4 schools of retention. One is occlusal, apical based school, and one is the muscular one, and also one is the Tweed's philosophy, wherein focusing on the incisor, lower incisor position. And we focused on 10 theorems of retention. And we moved on to which moleclution associated with which retention appliance to give, and which conditions require prolonged retention, like midline diastema, spacing, and rotation, and which required a surgical intervention like rotation, supracrystal fibrotomy, and what are the different kinds of retainers like Hawley retainer, Beck's retainer, and what is tooth positioners, how they can be used and why are they used, and the factors which lead to relapse and what can be done to prevent relapse. So all these are covered in today's topic, and I hope you got a big concept coverage of retention and relapse. If you have any comments or if you have any doubts, kindly put it in the comment box so that I can understand it. Okay, I have one question from Mohammed. He asked Beck's retainer for class 2 only. No, if you want to maintain the position of premolars and molars, then you can go for Beck's retainers as well. And sometimes after a functional appliance, which is mostly indicated in class 2 scenarios, then you would use an inclined plane to maintain the class 2 position. Imagine in class 2, right? The upper incisor will be way more ahead and the lower incisor would be here. So you're bringing it here to this space, and sometimes it will have a relapse associated with it. So generally following a functional appliance, we give an inclined plane. So that is a retention for keeping it in the forward position of the mandible. So usually in class 2, we give an inclined plane at the end of the functional phase to just keep it in position. This Beck's retainer, it can be given in cases wherein you wanted the premolar to be further in occlusion to the lower premolar, or you wanted mild expansion in the premolar region. So in such cases where you need some changes in the premolar and molar, you can use the Beck's retainer and incorporate some bends in it to correct it. But usually Beck's retainer is more stable when you compare it with the Hawley's retainer, because it covers almost from molar to the other molar. So yes. So if you have any other queries, kindly let me know so I can address all your doubts in on this slide. Or else we'll just wrap up today's session. Uh, with the hope of clearing all your doubts with respect to retainers and relapse conditions. Let's finish today's session. Looking forward for tomorrow's session as well. Thank you and have a great day.